Thanks everyone for joining today's webinar that will prep you for your participation in Consumer Voices Hill Day next Thursday, July 18th. So just a couple of housekeeping items. Your lines are all currently muted. As we finish the intro, I'll go ahead and unmute your lines, but just be mindful of keeping your noise level to a minimum. And if you can, it would be great if you could mute your mic on your computer, or if you dialed in with the phone, then hit the mute button on your phone. If you've got a question, you can type it through your Q&A box on the chat. You'll find the controls for each at the bottom of your screen. Since this is a smaller webinar, you can also say your question out loud and we'll try to respond as they come up or save them for the Q&A at the end. And finally, we'll be disseminating the PowerPoint for today's webinar after it's over. So you'll get that via email. So with that out of the way, let's get to the webinar. Just a little bit about Consumer Voice. So we're a national nonprofit organization in Washington, D.C. that advocates for people receiving care and services at home, in assisted living, or in a nursing home. We provide information, resources, and technical assistance to empower consumers, families, caregivers, advocates, and ombudsmen to seek quality care. We also have a national action network, which includes people like you who want to advocate for people who are receiving long-term care. So as mentioned in the emails, this is Consumer Voice's first ever Summer Hill Day. We decided to do this Day of Advocacy so that consumers, family members, and other advocates may carry the message about important protections for residents and quality issues in long-term care facilities before their members in Congress. It's really important that your members hear from you about all the issues that you or your family member might be facing in your district. So our presenters for today include Toby Edelman, Senior Policy Attorney at the Center for Medicare Advocacy, Robin Grant, Director of Public Policy and Advocacy at the National Consumer Voice for Quality Long-Term Care, and myself. So with that, I'll pass it off to Robin to talk about pre-dispute arbitration.
Okay, thank you, Alicia. So let's go to the next slide. Okay, so to begin with, let's just talk for a moment about what arbitration itself is. So it's a legal process in which you have a dispute or a lawsuit, a legal action that's settled by an arbitrator instead of, for example, a judge in a courtroom. And it's the arbitrator in this case who decides the outcome. So in any legal action, you always have the option to pursue arbitration. And in some cases, it may be a good option for some people. It depends on the circumstances, depends on the people. So we're not saying here that arbitration itself is bad, but the issue that we're very concerned about here is when people are forced to decide about whether or not to choose arbitration before the dispute arises. So that's what's known as pre-dispute arbitration. And increasingly, we're hearing it referred to as forced arbitration. So that means that even before you know what the dispute or the problem or the claim is, you have to agree to arbitration. And in terms of long-term care and particularly in terms of nursing home care, you know, that dispute, the term dispute itself sounds very minor and marginal, but we're talking very serious issues here. I mean, the quote-unquote dispute can be severe neglect, it can be severe injuries, or even death. So these are very serious issues here. Our organization and Toby's organization as well, along with other advocacy groups, have been advocating to ban this pre-dispute arbitration for years. And We were extremely thrilled when in 2016 there were revised federal nursing home rules that came out, and they included a ban on these pre-dispute arbitration agreements. Unfortunately, our delight and joy ended pretty quickly because the American Healthcare Association, which is the trade association for primarily for-profit nursing homes, took legal action and blocked the implementation of that rule. And then in June of 2017, the Centers for Medicare and Medicaid Services, which we refer to as CMS, issued a proposed rule that would allow nursing homes to continue to use these agreements, but actually the proposed rule went goes even farther, and it would also allow nursing homes to require residents to sign these agreements if they want to be admitted. So we are now waiting for that rule to be released, and so we don't know yet what it's going to look like. Okay, next slide, please. So let's talk just a little bit about why these pre-dispute arbitration agreements are so bad and really do harm consumers. So there are numerous reasons. To start with, they place consumers at a real disadvantage. Now, in a nursing home, we're talking about during the admissions process here. So, as many of you may know, nursing home admissions tend to be unplanned for the most part, and the admission process can be extremely difficult and confusing for residents and families. People are usually under really extreme pressure to find a nursing home for themselves or for a loved one, and often have very little time to do so, and have to find something very, very quickly. So it puts people in a stressful position where they often don't have the time really to look around when choosing a nursing home. So they're at a disadvantage in that respect. They also don't have the time to think through the pros and cons of arbitration when they're being admitted or admitting a loved one. I mean, the last thing that you want to be thinking about when you're admitting someone is what you're going to do if they're abused. You need to be and should be thinking about the quality of care and the range of services that are available, not thinking about whether their legal rights will still be available if they are abused or neglected. Consumers are also at a disadvantage because these agreements basically are offered on kind of a take it or leave it basis. So consumers are often feel forced into signing these agreements because leaving it may not be an option. I mean, that means trying to find another nursing home right then and there. And if you have a loved one who needs immediate care, and or the other facilities are very far away, leaving it may simply not be an option. And so I think, frankly, consumers are in essence being held hostage in this respect. So definitely at a disadvantage. And then finally, consumers are really at a disadvantage because the whole, everything that goes on at admission is just, it's such a stressful time. People are given just a huge amount of paperwork to sign, and these agreements can often be buried within the fine print of admission contracts and may go unnoticed, or may simply be handed to you and said, here, just sign here, you just keep signing because you need to get through that admission process so your loved one can be admitted. So that's numerous reasons why consumers are at a disadvantage. These agreements also basically strip people of their constitutional right to a trial by jury. We all know that we have that right. But when you sign an arbitration agreement, you literally sign away forever your constitutional right to a trial by jury for the particular dispute that might arise later. I mean, this is a very big decision when it's made, and people get sort of pressured into signing these kind of almost blanket agreements in advance without having any idea what they might be arbitrating, and with only the information that the facility chooses to give you about what arbitration is about. I mean, I've heard facilities that just hand it to people and say, this is just how we handle problems that might arise. Well, that's not exactly full disclosure, to say the least. When consumers pursue arbitration under these circumstances, they basically lose the benefits that they can get in a court of law, and which under other circumstances, had they not been forced into it, they might have chosen to actually go to court instead. So there are many ways in which they lose those benefits. Very often under those agreements, it's the nursing home or the long-term care provider that selects the arbitrator. They often decide where the arbitration will be held. And there is a, this is a money transaction here. So there's a strong nursing homes pay for arbitration. And actually the consumer may end up paying a part of the fee as well. But there's a very strong incentive for arbitrators to find in favor of the providers so they can get repeat business. So that certainly denies, you don't have that dynamic in the court of law. So in arbitration, in addition to hiring a lawyer, as I said, you also have to pay a part of the arbitrator's fee. So again, that's not what happens in the court of law. Arbitration can be costly and can be more expensive than going to court. And then there are basic procedures that you don't have in arbitration. So for example, if consumers can't appeal a decision that's made by an arbitrator, as you can in the court system. And then the last point I just want to make about why pre-dispute arbitration is so bad is that it prolongs misconduct on the part of the nursing home, and I also want to say other long-term care providers, and kind of hides information about dangerous conditions and practices. The information in arbitration proceedings is usually confidential. So the public, and that means current and prospective residents and families, aren't going to know about the nature of what's being arbitrated, which often may be alleged abuse and neglect. So the provider, the nursing home, gets to hide behind a shield of secrecy. And as a result, there's no public pressure to improve because no one knows. And then residents and families end up making decisions about choosing or remaining in the facility because they lack information. They're basically in the dark. Next slide. So what we are asking you to do in your visits is when you talk to your member of Congress, to make 2 asks. That's what we refer to these things. You're making an ask. So the asks, there are 2 here. One is to support and co-sponsor 2 bills. So HR means it's a bill on the House side, and SB is a Senate bill. So we have 2 bills, HR 1423 and Senate Bill 610. They are identical, and these bills are called the Forced Arbitration Injustice Repeal, known as FAIR Act. So it's referred to as the FAIR Act. People love acronyms and go to great lengths sometimes to fit a word into an acronym. So what this bill does, it's a broad bill that applies to consumer contracts in a number of settings. So certainly applies to nursing homes. It would apply also to assisted living. It would apply to credit card companies, phone companies. Those aren't the ones that we're interested in. But if this were to pass, it would accomplish, it would end pre-dispute arbitration agreements in nursing homes and other long-term care settings. And so that would be what we're trying to achieve. The other ask is for your member of Congress to support, and or co-sponsor legislation that would end the use of these pre-dispute agreements in long-term care settings. So certainly in nursing homes, and then in settings where there are providers that receive Medicaid funding. So for example, there are some assisted living communities that receive Medicaid funding, so this would apply to them. We don't have bill numbers to give you for this legislation, but we know that there's going to be a bill on the House side that's going to be co-sponsored by Congresswoman Sanchez and Schakowsky. And there's going to be an identical bill in the Senate sponsored by Senator Brown. So we will be giving you issue briefs for each of the issues that we're talking about today. And so there'll be some more detailed information on that about arbitration. And with that, I'm going to turn it over to you, Alicia.
Great, thank you. So we're going to move on to the long-term care ombudsman program. Under Older Americans Act, every state is required to have a state long-term care ombudsman that addresses complaints and advocates for improvement in the long-term care system. Each state has an office of the state long-term care ombudsman, which is headed by the state long-term care ombudsman, and that ombudsman designates staff and volunteers. So together, this makes up the ombudsman program in each state. Program representatives advocate for quality of care for residents. So this includes anything from when residents want to get up in the morning, receiving their medications in a timely manner, to serious issues of abuse and neglect. They also advocate for changes in law, regulations, and policies that better quality care and quality of life for residents in those facilities. In addition to all of this advocacy, Ombudsman program representatives resolve complaints. They educate consumers and long-term care providers about residents' rights and good care practices. They also promote community involvement through volunteering opportunities. They provide information to the public on nursing homes and other long-term care facilities and services. They provide information on residents' rights, legislative and policy issues. And they promote the development of resident and family councils. So they do quite a lot for our long-term care residents. So why is this program important? Well, simply put, without it, nursing home residents, assisted living residents, and those receiving care at home and in the community would not have an advocate that provides education, empowerment, and resident-directed complaint investigation and resolution. Residents and families across the country need the help of Ombudsman program representatives to help with complicated issues that arise for residents living in a long-term care facility. And sometimes an ombudsman is the only person a resident has to help them with their concerns with their care or their life in the facility, especially when that resident might not have family or friends to visit them. So, as of now, the long-term care ombudsman program needs more resources. I've included some stats on the slide in front of you so you can kind of see where the program is currently. So right now, there's one full-time equivalent for every 2,355 long-term care facility beds. And so that is just the average across the country. And the recommendation is that there's one full-time equivalent to 2,000 beds. So we're already over by 355. When you think about that, the Ombudsman program is stretched very thin. In 2017, 68.4% of nursing homes received visits on a quarterly basis, but only 30.2% of board and care, assisted living, and similar homes received visits on that same basis. So they're really not getting out to those types of facilities as much. And then finally, funding has only increased by $8.3 million since 2010, even though the population of long-term care consumers is rapidly growing and is projected to more than double by 2050. So as Robin said, here's your asks for the Long-Term Care Ombudsman program. Through the Older Americans Act reauthorization, which will happen this year, you should ask your members in Congress to update the maintenance of effort and minimum funding provisions in both Titles 3 and 7 from FY 2000 to FY 2019. So just to explain that a little bit, maintenance of effort is a requirement placed on the Ombudsman program that they demonstrate that the level of state and local funding remains constant from year to year. So by updating it from 2000 to 2019, which is a 19-year difference, this will ensure that funding for the state long-term care ombudsman program is not cut during state budget crises and when additional funds may be provided by the federal government. The second ask here is to increase the current Title VII State Long-Term Care Ombudsman Program authorized funding level to $35 million. So this is a really long-needed increase, and it would help to improve the quality of life and care that millions of vulnerable residents receive in our facilities. It would help support the Ombudsman program to do more effective and more complaint investigation and resolution and all the other activities we talked about before that they do. The third ask is to create an authorization of $20 million for funding for Ombudsman services to assisted living residents. As you saw from the previous slide, residents in assisted living do not have regular and timely access to long-term care Ombudsman program representatives. This additional authorization will support the Ombudsman program to work with these residents. And then finally, the fourth ask is to include the volunteer Ombudsman representatives designation in the OAA. So as we discussed earlier, the program is filled with volunteers and they provide a really critical and necessary role to help advocate for residents. So this ask is a technical fix that would ensure that all Ombudsman programs are able to provide financial support. So that would include something like reimbursing transportation to visit a facility. And that would help volunteers to participate and serve the program in cases where they may not be able to if they weren't able to pay for that kind of transportation. So with that, I'm going to pass it back to Robin to talk about the federal nursing home regulations.
Okay, thanks, Alicia. So in October of 2016, the Centers for Medicare and Medicaid Services, and I just will refer to it as CMS from now on, published revised federal nursing home regulations for all nursing homes that participate in the Medicare and/or Medicaid programs. So the regs are technically referred to the requirements of participation because that's what facilities have to meet. They have to meet these requirements in order to participate, in Medicare and/or Medicaid. So this was in 2016 when the regs were released, the first time that these regulations had been updated since they were released for the very first time in 1991. So decades had literally passed since they had been released. A lot of time and effort went into revising these requirements of participation. It took more than 4 years of work. There was extensive input from a range of stakeholders, including advocates and including the nursing home industry. and over 10,000 public comments were received, which CMS had to review and evaluate. So it was an extensive process, lots of thought and input went into it. The revised regs really include, we think, very important improvements and new protections. And these really better promote quality of care, quality of life, and strengthen residents' rights. So these are these updated regs, we believe are stronger. They include a focus on person-centered care, so really looking at what it is that the resident wants and having care flow from what that person likes, wants, and directs in terms of their care. There are improved protections against abuse and neglect in there, improved staff training, the notice to, there are better protections in terms of evictions of residents, including notifying the Ombudsman program when there is a discharge initiated by the facility. Required infection prevention is included. So there are lots of areas where there are improvements. And you can see some of those on your screen. I do want to mention one, which is the last point there, a facility assessment to determine what resources, including staff, are needed to care for residents. I want to point that out because we had advocated very, very strongly for minimum staffing standards. And we did not get that, but I think this was kind of the consolation prize, I guess, if you will. I mean, what this says is that a facility has to really look at the residents it has, their acuity level, their conditions, and determine the level of staffing they need to care for their residents. So when this is developed and if it's effectively implemented, it really means that facilities have to determine the staffing level that they really need, and they have to provide that level. So we think that this is a very important provision because it at least helps us, we hope, move in the direction of better staffing levels. Okay, next slide, please. So this all, you know, the regs sound great, and we were extremely excited about them, but unfortunately, almost from the time of their release, the regs have been under attack. I think, as I mentioned, the nursing home industry went to court over the arbitration rule immediately. Then in January of 2017, it was a new administration, a new Congress. There was consideration in Congress of repealing the entire regulation. Since January of 2017, members of Congress, at the request of the nursing home industry, sent letters to CMS, urging CMS to get rid of or modify the regs. I mentioned there's already a proposed rule out there to roll back the ban on arbitration agreements. And the nursing home industry has met repeatedly with CMS asking for the regs to either be watered down or reversed. And then in line with those requests from the nursing home industry, CMS announced in the fall of 2017 that it was once again going to issue proposed nursing home regulations, despite the fact that all the regulations that were part of the that are part of the 2016 regs haven't even been implemented yet. So the question is, why is there this push to ease up on these regs? I mean, why are we seeing this push to weaken them or even get rid of them? So this push is coming from two places, and these are kind of intertwined, actually. Nursing home industry, first of all, has been a strong proponent of rolling back the regulations. From the very start, when they were released, the industry has claimed that these standards are excessive, they're onerous, they're unnecessary, they are too detailed, too prescriptive, and they micromanage how nursing homes operate. So what they say is that the regs need to be changed to give them more flexibility. It's the facility, in their opinion, that knows best what is needed, and they should have the flexibility to do what they think is appropriate. So that's what the nursing home industry has been saying, and they've been saying it to CMS from the start. In terms of why CMS is going after the regs, well, frankly, it is responding to pressure from the nursing home industry, but it's also it's a philosophy, frankly, of this administration, which is a deregulatory philosophy. So CMS has been saying that it needs to and will reconsider the regulations in order to eliminate anything that's excessively burdensome, that's unnecessary, and we hear a great deal about they want to reduce the burden on providers. And so that has been the focus really since the beginning of this administration, is to make things easier for nursing home providers, not to increase the protections for residents. So that's where we are in terms of the attack against the regs. Next slide, please. So we have been, and along with other advocacy groups, pushing back and advocating aggressively that these regulations should not be weakened. Frankly, if anything, they should be further strengthened, but they should be retained. The regulations should be kept as they currently are. So the question is, why? Why do we think that the regs should be retained and not modified or eliminated? So there are a range of reasons, many reasons, but I'm just going to give you the very short version. First, the regulations should be kept because, frankly, these regs, which are stronger, are needed. They're needed because people in nursing homes now have higher care needs than they did in the past. And the majority have dementia at this point. And that means that they need more assistance and are more vulnerable and therefore need more protections. Their stronger regs are also essential because we still have poor care, abuse, and neglect occurring in our country's nursing homes. Study after study, report after report show that this continues to be the case. And just one quick example, there was an Office of Inspector General report back in, I believe it was 2014, that found that one third of Medicare beneficiaries, so these are individuals who came out of a hospital, went into the rehab, the skilled nursing part of the facility, and within only 15 days of being admitted, the majority, one third of them were harmed, and the majority of that harm was considered to be preventable. So we still have far too much abuse and neglect, and so this is an instance where we should not be reducing the regulations that are on nursing homes. So that's one big reason why the regs need to at least remain as they are. The second reason is that from our perspective, reducing the burden on providers is, first of all, not needed, and second of all, could be harmful to residents. So I said that providers say that the regulations should be revised to give them flexibility. What they don't say is that the rules actually include a lot of flexibility already. So just to give you one example, there's a requirement that all staff need to be trained in certain topics, and those topics are mandated. But the regs don't say one word about the amount of that training or the frequency of that training. That's totally up to the provider. I mean, that's certainly one area where I think as advocates, we would have felt that, you know, the frequency and the amount of training should have been spelled out, because really, you know, otherwise it's just totally left up to the facility, as is the case here. So that's a lot of flexibility. And there are many other examples. And I would say there are areas where the language is prescriptive. And it's there because the nursing home industry has failed to act. So what we have seen is when there is flexibility, what we often get as a result is inaction by providers. So that's why we think that this reducing the burden is not needed, because that flexibility is already there. And sadly, we really do need very specific detailed language in many cases, because unfortunately, far too often, there are you know, providers who are only going to do what they're absolutely required to do and no more. So then we have to make sure that what they absolutely have to do is enough to ensure quality of care and quality of life. So reducing burden is not only not needed, a lot of negatives in that sentence, but we are convinced that it can also be harmful to residents. And I want to give you just one example. So CMS has been saying, well, we're going to reduce burden, so that will give administrative relief to nursing homes, but at the same time, we're going to continue to protect resident health and safety. What we believe is that if CMS moves in that direction, that many of the revisions are likely to end up undermining resident health and safety, not protecting it. And just one example, in the revised 2016 regulations, nursing homes are required to report allegations of abuse or neglect to the administrator and to the state survey agency. That's been a requirement for a while. But what is new is that if there is abuse or neglect that's caused serious bodily injury, then that needs to be reported immediately, but not later than 2 hours. So there's a 2-hour time frame there. That was not there before. So this serious bodily injury is truly serious. I mean, it's something where an injury that's maybe caused extreme physical pain, this is how it's described, involves a substantial risk of death, needs immediate medical intervention. So this is very, very serious stuff. So the nursing home industry, however, has indicated it doesn't want this 2-hour time frame. So if that's removed, what does that mean? Well, we think that it can result in residents being harmed, because residents who have suffered, potentially very life-threatening harm are very likely to not get the prompt attention they need that could result in death or even permanent impairment. And then representatives from the state agencies are not going to respond quickly enough to investigate and preserve evidence, which is really important, so that you don't compromise the investigation, which would result in the abuse being very likely to continue. So this is definitely not an example of protecting resident safety. So reducing burden can harm residents as well as being unnecessary. Okay, next slide. So here's the ask, and this one is, we don't have a piece of legislation in this case. So sometimes we ask members of Congress to put pressure on CMS because their voice carries a lot of weight, or can carry a lot of weight with federal agencies. So what we would like to ask you to ask your members of Congress is to retain the federal nursing home regulations as issued in October of 2016. So that's a very sort of simple ask, but very, very important. Okay, I think now I'm going to turn it over to Toby.
Okay, thank you, Robin. Thank you, Alicia. I wanted to briefly discuss an issue that prevents residents from using their Medicare benefit to pay for their stay in a skilled nursing facility, and that issue is observation status. What we mean by that is a patient who's in the hospital. Typically, a person goes to the emergency room and the physician there says, we're not sure what's wrong. We need to look at you some more, do some more tests. You need to stay here. And so the person goes upstairs to the relevant part of the hospital, coronary or whatever it is, and gets a wristband, starts receiving care, gets medical care, nursing care, tests, medications, whatever is necessary. The problem is the person is being called by the hospital an outpatient receiving observation services. We don't call it observation services because there are no services that are specifically observation. So we call this observation status. The reason this matters is that Medicare Part A will pay for a stay, that up to 100-day benefit, only if the patient has been hospitalized for 3 or more consecutive days, not counting the day of discharge, as an inpatient. That's the statutory language, 3 days as an inpatient. Because Medicare, when it counts time, it counts midnights, not 24-hour periods. Our way of considering what an inpatient status means is 3 midnights. Need to be an inpatient for 3 midnights in order for Medicare Part A to pay for the nursing home stay. So when the hospital calls somebody an outpatient instead of an inpatient, then the person doesn't qualify for Medicare Part A coverage. The person does qualify for Medicare Part B. So if the person goes to the nursing home as a private pay person and gets therapy, that is a Part B service. The care is generally indistinguishable between inpatients and outpatients. There are no observation services. There are no specific services that only outpatients receive. And in the preamble to various sets of regulations that CMS has been writing about this over the last decade, it says explicitly that the physician for the patient can order whatever tests, whatever medications, whatever treatments the person needs, whether the patient is an inpatient or an outpatient. So from our perspective, observation status is not a care issue, it's a Medicare billing issue. Question is whether the hospital will bill Medicare Part A for the care or Medicare Part B. Next slide, please. So we have had hundreds of calls about observation status over the last decade. And I must get myself 2 or 3 a week. So I wanted to share a couple of calls that I got within the last month. One of the most recent calls was from a son-in-law of a World War II veteran in upstate New York. The son-in-law himself was the chief operating officer in a hospital, so he knows quite a bit about hospital care. His father-in-law was living in assisted living, and the assisted living staff were concerned that he might have had a stroke, and they said, we need to send him to the hospital. So he went to the hospital, and he went from the emergency room to a bed. He stayed for 3 days. 2 days were called observation, and then he was called an inpatient. So he had 1 inpatient day, not 3. They don't count the observation days. So his sniff stay was not covered. The son-in-law told me that in order to get the father-in-law admitted to the nursing home, that day they had to pay $11,861 for 1 month in advance, which they did. The father-in-law stayed a little bit more than 2 months, and the total bill was almost $35,000. Now, because the hospital made the man an inpatient after the 2 days of observation, the hospital got the inpatient rate for this man, but Medicare Part A did not pay for this man at all. If the hospital had called him an inpatient for all 3 days, Medicare would have paid for his SNF stay, certainly the first 20 days and probably some more. And if he had Medigap insurance, that would have covered it. Next slide, please. Another call was from a woman who called me, I believe in Rhode Island, and she went to the hospital for scheduled knee surgery. This is sort of atypical, but you know, every day is another crazy story. So she stayed in the hospital for 3 days on observation for her knee surgery. Of course, she was on observation, so Medicare would not pay for her nursing home stay. All she could afford was $455. She could only afford 10 days worth, $455 a day. So it's $4,550 for her 10 days in the skilled nursing facility, which I believe she paid for by dealing with her home equity line of credit. What is really bizarre about the case is that 10 years earlier, she had had knee surgery on her other knee, same hospital, same physician, but she'd been called an inpatient. So Medicare paid for her hospital, and it paid for 3 weeks in the SNF for rehabilitation. Now she got nothing, just had to pay out of pocket. Next slide, please. So this is a common issue. The Inspector General wrote a report in 2016 indicating that 633,148 patients in fiscal year 2014 alone had spent 3 or more midnights in the hospital, but some or all of those nights were not called inpatient. So even though they were there 3 midnights, they did not have a 3 midnight inpatient stay. Now, not all of those people went to nursing homes, obviously. Some people go home, some people, just go to assisted living. But the primary institutional setting after the hospital is a skilled nursing facility. So there are lots of people that this is happening to. They're finding themselves having to rely on their families, their adult children. One case I had, one situation, it was the nephew who came up with $7,000 for his aunt that day so that she could get into the nursing home. So this is a very common problem for people. They're in observation and their nursing home care isn't paid for. I just want to say one other thing. There are other consequences that we've heard from over the years. One possibility is that people don't have Part B. If they don't have Part B, they're considered uninsured by the hospital. And one woman told me she was in the hospital for 22 hours. She went home, they didn't find anything, but she didn't have Part B. And so her bill that she was expected to pay out of pocket from the hospital was $22,000. And sometimes we've heard from people who have very large drug bills because the hospitals are allowed to bill patients directly for drugs that they're receiving. And people are concerned that they have the drugs at home, not allowed to bring them into the hospital. So they're paying for drugs that they have, and they're paying, as we all know, very inflated prices for drugs. Aspirin is $7. You can imagine what other things are. So the big problem is nursing home care, but there are other consequences that you just might want to be aware of. Okay, next slide, please. So there's federal legislation called Improving Access to Medicare Coverage Act of 2019, HR 1682 and S 753. These are identical bills. They're bipartisan. There are Republicans and Democrats on both bills. And it's the substance of the bill is one sentence. It counts all the time in the hospital. If you're in the hospital for 3 midnights, you've met the requirement for a 3-day stay. That's it. It's very straightforward. It's very simple. It doesn't say much of anything, just count the time. I would say that when Medicare was enacted, and this is where the 3-day stay requirement came from, in 1965, the average length of stay in the acute care hospital for people 65 and over was 13+ days. So pretty much anybody who went to the hospital was going to get a 3-day stay. Now, we don't have the numbers for 65 and over, but the average length of stay in the hospital is fewer than 5 days. So when hospitals are calling people inpatients or outpatients for 2 days, and then giving them inpatients for 2 days, that's not giving them 3. It only gives them 2 days of inpatient stay. So it's really definitely a problem for people. We have an ad hoc coalition of more than 30 national organizations that are supporting this legislation. And partly, one of the things you'll get is a copy of that 2-page statement. But the most interesting part to me is the part on the left, the organizations that we listed of everybody that supports this. And there are a lot of organizations that we don't generally work with that are on this legislation, like the American Medical Association, but various organizations of providers are on this. The emergency room physicians, the hospitalist physicians, emergency room physicians, of course, of the nursing home industry, they signed up first. They were the first ones there. American Healthcare Association, Leading Age, all of the advocacy organizations, AARP is on this, everybody is on it, and there is no organized opposition to this legislation. But it's been around for 8 years and it doesn't get passed. And that's because Congress doesn't pass very many laws these days. Everything has to have a vehicle. This does not have a congressional budget office score, so we don't really have a sense of how much it would cost. We've heard various estimates from 0 to, I don't know, 14 billion or something. It's a range. It's a little bit of a range. But we are trying very hard to get this passed. So next slide, please. What we're trying this year as a new strategy is to have observation included in the surprise medical bills issue. There's a tremendous amount of interest in Congress in this issue, and there have been hearings and there are markups. I mean, they're quite serious about this. I even saw an ad when I was at the health club from doctors complaining about it. So you can see this is really moving. This is serious legislation. What the surprise medical bills typically talk about, and what they mean by that term, is somebody who has health insurance and goes to a hospital that's in the network of that health insurance plan, and then the person also has the physician who's in the network. So they think, I'm covered, I'm in the right hospital, I have the right doctor. But then they suddenly get a bill from the anesthesiologist. They had no choice about that doctor, they didn't know who the doctor was, but that doctor is not in the network and sends a surprise bill, $5,000, $10,000, whatever. People are very concerned about that. It's a very, very common problem. And but the principle of it is there's a big bill that you have no choice about. You couldn't have predicted, you couldn't prevent it, you had no knowledge, but you're getting this large bill. We're saying observation status is the same exact thing. You don't have any choice, you don't have any control, and there's nothing you can do about it. In fact, Congressman Courtney, who's the chief sponsor in the House, says observation status is surprise medical bills on steroids. It is really a serious problem for people. So we are hoping this year, and we would ask you when you talk to your members to say, please include observation status in the surprise medical bill issue, or pass the legislation, the Improving Access to Medicare Coverage Act of 2019, because so many tens of thousands of people are affected and they're being denied their Medicare benefit. So that's what I want to say about that, Alicia. Maybe we should turn back to you.
Great. I actually think Robin is next to talk about the advocacy tips.
Thank you, Alicia. I'm conscious of the time, so let me ask you, Alicia, are folks going to receive a copy of the PowerPoint?
Yes, they will. They'll send them by email.
Okay, super. So because we still have some other things to cover, and we're running out of time, and we'd like you to have a little bit of time at least to ask some questions. I am not going to go through all of these tips, but you will get them in the PowerPoint that's emailed to you. So I'm just going to highlight just a few of these points. The second point is I refer to kind of packaging the different issues together under kind of the umbrella of I want to talk to you about concerns about nursing home residents. So we've got 4 issues here, and we'd like you to be able to talk or at least touch on as many of them as you can, hopefully all 4. So the way to frame it, I think, is to say, I'm here today, Senator so-and-so, to talk to you about concerns related to nursing home residents. And then you sort of go through the different issues, but that's kind of the unifying theme. I said, I'm here today to talk to you, Senator so-and-so. I do want to tell you now, you are all making arrangements to meet with your actual members of Congress. So you are constituents. So hopefully you actually will be meeting with your senator or with your congressperson. But that's not necessarily always guaranteed. First of all, they never know what's going to come up. So I just want you to know, if you haven't done this before, that you may in fact be meeting with a staff person. So don't think that you're being disrespected because you're not meeting with the member of Congress, but with the staff person. When we go out and do these visits, we never meet with a congressperson. It's always a staff person. So that's just how this works. And I have to tell you, with very few exceptions, I am always very impressed, usually very impressed with the staff person. For the most part, they're very sharp, they're very knowledgeable, and on top of things. So don't be disappointed. And maybe at least you can have a photo op with a member of Congress. I plan for 30 minutes. It is very rare that you will have more than 30 minutes. They often have back to back, if you're particularly with a staff person or particularly with a member of Congress, but they're booked. So plan for that, but be prepared at any point for it to be, for you to have less time than that. It is not unusual to have a staff person come in and say, I'm really sorry, I only have 10 minutes or only have 5 minutes or whatever. Or you're talking to them and then all of a sudden, they have to get up and leave. So be prepared to ask what you need to ask with a quick explanation in 5 minutes, which is why you want to, at the bottom point here, put your ask up front. So right in the beginning when you're introducing yourself, we're here to ask, Senator so-and-so to support, and then go through that. And then you talk more in detail about the different issues. But at least if somebody has to get up and leave, you've already at least gotten your ask out there so they know why you're there. So with that, I'm going to stop. I had asked Eileen if she wanted to add anything to this. So can we open up Eileen's line, or however you want to do it, Alicia? So she might say a few words. And Eileen, I have to ask you to be super brief.
Yeah, I've unmuted her line. So Eileen, if you can just unmute your mic.
So hopefully you can hear me. Is that a yes?
Yeah.
Great.
Yes.
So I just want to share, having had the opportunity to do a lot of different kinds of things over my time as an ombudsman. In reality, any one of those things that Robin talked about is going to happen or can happen to you. More importantly, I do have to share, I had a surprise one time where I knew I was meeting with a staffer and was invited in to sit with our senator from Maryland. At that time, it was Senator Mikulski, on a Hill day, because I happened to mention something that was near and dear to me, and the staffer cued somebody else in their office, so that I actually ended up with an entree and sat with the senator for over an hour, which was a fabulous experience. And then I came back to it happened during the Consumer Voice Conference, and I was excited because I got to come back and tell people that that had taken place. So what I will share is that if you do have a personal connection to a story or to something that you know that your congressperson has a great interest in, for example, you might have a congressional representative who is not a lawyer, but maybe has a different background in coming to Congress. And you may have a personal connection that you can share it. Put it in that first ask part. Talk about it. Talk about your own reason for being there, not just the agenda of this is a Hill Day and we want to make sure that every one of our Congress people knows something, because it will get you an ear that you might not have had otherwise. So that's what I'd like to share.
Thank you, Eileen. Very helpful. And wow, an hour with your member of Congress is phenomenal.
It was incredible.
Yeah, really. A world record there. Okay, so Alicia, I think you're next with logistics.
Sure. I'll keep this really brief in the interest of time. So at 9 a.m. or whenever you get to Capitol Hill, the first thing you'll want to do is just to check in with your team member on either the House or the Senate side. And so I've included the cafes that we're going to be at, and those links on the slide, they're clickable. So you can click on Longworth Cafe and then you'll see where it is. And it has like the phone number and directions on how to get there. So do that, because once you check in with us, then we'll give you your Hill packet. And after you've gotten your Hill packet, which includes a lot of the materials that we talked about today, the issue briefs, the 2-page fact sheet on observation status, and other materials about consumer voice, that'll be for your own benefit, but you'll also have folders to leave behind for each member in Congress that you visit. So you might get up to 3 folders depending on how many visits you scheduled. So if you're gonna be there the whole day, we do recommend that you eat lunch at one of the nearby cafes or restaurants. In your packet, you'll have a list of nearby places with phone numbers and food options on there. And then after each visit, just check back in with us, debrief, ask any questions. If there was something you weren't sure about in the meeting, or a question that you weren't anticipating, we're here to help you, and we will do our best to get the answers that you need. So after you're done with the visits, at 4 p.m., we're inviting you all to come to the Consumer Voice office in downtown DC for a group picture and to mingle with Consumer Voice board and staff at our annual open house and our Jackie Koenig Memorial fundraiser. So that's basically the logistics in a nutshell. I've included a slide here so you can see what's going to be in your packet. And your folder is almost identical to your congressperson's folder. You're just going to have those 3 additional resources at the bottom in your folder. So the advocacy tip sheet, the food options, and maps and directions. So you don't get lost, or if your phone's not working, you can still get around.